All right, you guys can see that?
Yes, we can.
Okay. Well, again, thank you, Dr. McCarty, for the opportunity to talk. What a great symposium. Thanks to everyone for chatting and speaking, and Dr. Kelly, of course. And I'm going to spend the next 10 minutes telling you why Dr. Noonan is wrong about his opinion on tenotomy. Just kidding, just kidding. There's a good option for everyone. But really, Tenodesis is the way to go. My disclosures are still listed online, and none are relevant to this talk. So biceps tendon pathology is real. It can be inflammatory. It can be due to instability. It can be due to a slap tear or superior labral tear. This is an example of one of my patients who had a chronic biceps tendon rupture, and you can see a very bulbous end to his biceps tendon and then a ton of tenosynovitis and thickening just along the entire course of the biceps tendon, most of which cannot be viewed arthroscopically, which is when a lot of us tend to diagnose or not diagnose biceps problems. So a lot of potential problems with biceps tendon pathology. And on physical examination, we can see multiple things, including groove tenderness. Then there's a variety of special tests, and we've discussed those earlier today in the physical examination talks in terms of determining biceps-related pain. And it's often associated with other dysfunctional shoulder conditions, including cuff tears, slap tears, and arthritis. What is the function of the biceps tendon? Well, this is up for debate, not really in the scope of this talk, because we could go on for hours and days, and there's whole symposiums dedicated to the biceps tendon. EMG suggests a minimal role, and biomechanics suggest a role as a secondary stabilizer to the shoulder itself. And I think none of us really truly know what function the biceps has. As noted by Dr. Noonan, you can have no biceps tendon and still throw for a Super Bowl. And so we don't really know how much function this tendon provides for us. But what we do know is that it's a pain generator when it's pathologic. And so that's exactly what we see here. If you look at that, you wouldn't want that in your shoulder. That's a nasty looking biceps tendon. That's a biceps tendon that's causing a lot of pain and needs to be treated surgically in order to relieve that pain, and for the vast majority of patients. We know that biceps pathology is common, and what's critical to understand is it's not always visualized arthroscopically. In this study published out of JSCS almost 2 decades ago, 200 patients were undergoing a simple subacromial decompression arthroscopically. 80% were known to have biceps pathology, but only half were seen arthroscopically. The rest was noted based on preoperative physical examination and imaging, and then noted once the biceps was taken out of the groove through an open approach. And so over half of the time, biceps pathology may not be visualized arthroscopically, and we can't really rely on that. So what is the treatment option for this? Either a tenotomy or a tenodesis. This is a tenotomy. This is how many of us do it, where we take an arthroscopic biter and we'll take the biceps off of the superior labrum attachment. You can use a radio frequency device or a shaver or scissors or a variety of other options to do this, and you could just leave it. And the question is anything else indicated like a tenodesis? And certainly, as Tom just mentioned, tenotomy is easy, it's fast, it's effective, it's safe and cheap, no implants, and really minimal problems with this, but not so fast, because, you know, that all sounds great, but really there are some potential downsides. And this is how some of my patients look at me when I tell them, yeah, I might cut your biceps and just leave it. And they look at me, even if I tell them the Brett Favre story or the John Elway story, and they look at me very skeptical like this. And so factors that impact decision-making include patient's age, their activity level. Are they a work-related injury patient? Do they have chronic symptoms? How extensive are those symptoms? And what other concomitant pathology like a rotator cuff tear do we have? And then certainly arm size and anatomy is relevant here. This patient's bicep is different than this patient's bicep. And so we have to be cognizant of our patient's anatomy and really tailor the treatment to the patient. Tenotomy would suggest, or the literature would suggest, that tenotomy is safe and effective, but there is a relatively high complication rate. When you look at this paper shows a 13.3% complication rate in 30 shoulders. That is not insignificant for a procedure that should be, quote unquote, very simple and easy. So while not all these complications are major, they're still there. And so that's something we do have to disclose to the patients. And that's higher, I think, than many of us think. What about cosmesis and patient acceptance of how it looks? Well, when you look at these two studies, some patients care, some patients don't care, but really no difference if they get a tenodesis versus a tenotomy. But there are patients who have deformity and cramping, up to 20% of cramping after a tenotomy. And so it's important to counsel your patients that that is a risk that we don't really see with tenodesis. And then when we look at functional outcomes, we can see in this paper published out of HSS, and we can see that 70% of patients in the 54 patients that had a tenotomy had a Popeye sign. Now, this doesn't bother everyone. So there's a difference between having the problem, having the cosmetic deformity, and really having symptoms from it. But still, this is a pretty significant number and something we need to be counseling our patients. And I think if patients knew these numbers, they may choose to have tenotomy less and less simply due to the cosmetic effect. And certainly there is some fatigue, discomfort, or cramping in this tenotomy patient population. What about when we compare tenotomy to tenodesis? Well, this is a tough comparison because not every tenodesis is created equal. And so when you look at the literature, it's hard to compare tenotomy to tenodesis because tenodesis can be performed arthroscopically. It can be performed through a mini open approach. There's a variety of different ways to do it. So we're not always comparing apples to oranges, or apples to apples here, I should say. But when you do look at the literature and you look at all comers, this was a systematic review of 19 studies, only one of which was a randomized controlled trial. The rest, or the vast majority of which were level 4 studies. The authors concluded there's a lack of strong evidence to advocate for one technique over another in terms of tenotomy versus tenodesis. This was a study published out of the Rothman Institute, another systematic review, again, mostly level 4 studies. And it showed that in patients who undergo tenotomy versus tenodesis, all of them really have good outcomes, but better outcomes in the tenodesis group and significantly more Popeye signs in the tenotomy group, as one might expect. And that's important because it's important to be able to counsel your patients on the potential downside. And I would note that the patients, when we compare outcomes that had superior outcomes with tenodesis, those were in patients undergoing concomitant rotator cuff treatment. When we were just looking at all comers, whether they had concomitant rotator cuff treatment or not, tenotomy versus tenodesis results were actually very similar. And they concluded that the only major difference between these two treatment outcomes was the cosmetic deformity that's associated with tenotomy alone, and patient-specific factors should guide the surgeon. So are there downsides to tenodesis? Well, certainly cost if you're using an implant and potential complications of adding a procedure. And complications are rare. And again, the tenotomy had a 13.3% complication rate in that one study that I mentioned. Complications after subpectoral biceps tenodesis have been examined by the Rush group and by my mentor who taught me how to do this procedure, Tony Romeo. And while complication rates are low, 2%, they can be devastating, including in very rare but devastating cases, neurovascular compromise and proximal humerus fracture. And so that can be problematic. And certainly we would hate to get an infection in this part of the shoulder, which is right near the axilla and could be impacted by P. acnes or now C. acnes. There's been a report of several cases of neurovascular injury, brachial plexus injury, and so we've got to be careful with that as well. I think using good technique and understanding your anatomy can hopefully avoid this, but even in expert hands, this can happen. The bottom line for me in my practice, and I think for many of us, we cannot recommend tenotomy for patients who have good athletic aspirations and pursuits, except in very rare instances. And we've discussed a couple of professional football players, including one who did have a surgical tenotomy. Absolutely anyone who's concerned about cosmetic appearance, we cannot safely predict how a patient's going to feel about a deformity that's quote unquote caused by their surgeon. So they come in with pain and they come out with a deformity and you're the only one that intervened. Some patients will blame the surgeon, even if you document, even if you've had extensive conversations about the potential for cosmetic deformity. Once they see it, they may not feel as strongly as they did in the preoperative discussion, and they may blame you as the surgeon for causing their cosmetic defect, for causing that cosmetic Popeye sign. And then finally, in workers' compensation cases, we don't really want to give the patients any reason to have continued pain or keep their case open. We want to treat any potential cause of pain. And in some cases, the cosmetic deformity may lead the patient to continue to experience pain. So what I ask I put up these 4 doctors as our group of surgeons and physicians here who spoke in this session. I would ask each of you, Dr. McCarty, Dr. Noonan, Dr. Dragoo, Dr. Provence, what would you prefer? And I think the answer is clear. We'd all like to have that biceps in the gentleman with the black shirt as opposed to the one with the white shirt. We'd all like to have a nice contour of our biceps tendon after a biceps tendon surgery. And so therefore, I would strongly encourage tenodesis over tenotomy in the vast majority of patients. Thank you all very much.